Hi everybody. Just waiting for Marina. We are going to be talking about pelvic health PT today for peds, so kids and kids 4 to 17, I believe, is what she treats, as well as adult pelvic health. So, pretty excited. Also, good morning, because it is definitely morning in the Pacific Northwest. Hey Marina, let me... Yeah.
Hi,
Good morning. How are
how are
you?
you? Good. Okay, I'm on here. You can hear me?
You're all good.
All right, awesome. Oh, this is so exciting.
I know. It's great to meet you finally.
You too. Thanks so much for having me do this.
Oh, well, thank you for agreeing. When you told me you did pediatric pelvic health, I was like, what? And I like wanted to
Yeah,
know more immediately. So
yeah, awesome.
cool.
Awesome.
Well, do you mind kind of introducing yourself a little bit and we'll kind of get the ball rolling after that?
Sure. So, my name is Marina Castellanos. I'm a physical therapist in Westchester County, and I specialize in pelvic health for women, children, and teenagers. I've been a PT for about 20 years, and I started out doing developmental pediatrics and made the switch to pelvic health in 2015.
Nice. So first of all, pelvic health, this is like the third pelvic health interview I've done, and every
Okay.
time I learn so much more, and it's amazing. The first one was just like an general overview. Second one was just on specifically like dancers and the athletic population.
Mhm.
And with each one of those, first of all, pelvic health is not really a common um, field that PTs necessarily go into.
Mhm.
How did you get into pediatric pelvic health specifically?
So, I mean, the first question I can answer is just how I got into pelvic health in general.
Yep.
So I actually was introduced to the specialty because I had my own issues with my own pelvic health. So I developed really severe pelvic pain. And in the process of going to rehab with my own pelvic floor physical therapist and in talking about, what I was doing in pediatrics, and I've been doing it for such a long time, at that point, she actually said to me, why don't you do this for children, meaning pelvic health? She said, nobody does this. There's a need for it. She said, why don't you take a course and see if you like it? So I did. So I took a course in pediatric pelvic floor health, and I loved the course, but I wanted to know more.
Hmm.
So in the pediatric course, in the introductory courses, you're not learning anything internal. It's all external based. So I ended up taking PF1, Pelvic Floor Level 1 through Herman and Wallace, and
Hmm.
I just absolutely fell in love with pelvic health. I said, oh my God, I said, I can't just do this for children. I said, I need to do this for adults too, because it was just mind blowing. And there's definitely still a need for adult pelvic health therapists because there aren't that many of us. So from that point on, I just decided to change specialties and just started taking, course after course after course, to gain my expertise. And that's what led me here today. And then because I do have the background with the pediatrics, I can still make a huge impact in pediatric pelvic floor health as well, which is really great because it's not like treating, little adults. So pediatric pelvic
Right.
floor health really is a separate specialty, that requires a lot of background, knowledge in peds. So being able to transition, to pediatrics was, pretty easy for me because of that background that I have.
Yeah. So I wanted to ask you too, because kids can't really communicate to their parents or their supervisors or their guardians, like, I can't go to the bathroom because this hurts or whatever. They just cry. How do people end up getting to you? Like, what is the
So,
normal route?
so it depends on what's going on. So I worked with children as young as like 18 months, who have constipation. And, I've worked with children, young children, like, 4 years old who have bedwetting, 5 years old who have bedwetting, and then up through, teenagers. So it depends on what's going on. Obviously for a baby, a toddler, a parent is going to realize if there's constipation, if they're not going to the bathroom, if they're not urinating enough, and so forth. And really just doing like their work on Google. They'll find me doing a Google search. I'll get some referrals from doctors, from other therapists in the area who don't see pediatrics. And then a lot of people, even children will, or adolescents, I should say, they'll seek out, help on Google too. If they have things like pain going on. But really some of the things that parents can look out for is, is a child refusing to go into the bathroom? Are they refusing to sit on the toilet? Some behavioral issues might be popping up because a lot of times children will have a negative association with going into the actual bathroom itself, even though the bathroom is not causing, their pain. They're just associating, maybe the last time they had a painful bowel movement, it was while they were sitting on a potty seat in the bathroom, and then it hurt and they were really uncomfortable, and now they refuse to go in there because they're associating pain with the bathroom.
Right.
Yeah. So those those are a couple of general things that, signal to a parent that something is off. But it really can kind of show up in a bunch of different ways.
Cool. So you kind of touched on it already, but what are some some of the more common things that people come to you for, especially with their kids?
The most common things are usually bedwetting and constipation, and they all can be really closely linked, as well as fecal incontinence, encopresis, which is fecal soiling. So they all can be really closely connected. So I have people coming to me sometimes after dealing with constipation with their children for years, and they've gone through, invasive testing and, anal rectal manometry and biopsies and colonoscopies and all this stuff. And, at the end of it, there was no improvement. And finally, somebody said to them, why don't you try pelvic floor physical therapy? So I wish I was the first on that list of,
Right.
treatment options, because what I do is conservative. But that doesn't always happen. Yeah, I wish it did. Yeah.
Yeah. As an outpatient orthopedic therapist, we see that all the time too. And I specialize in chronic pain stuff, and it's just amazing how many providers people go through before getting to somebody where they're like, oh yeah, what you're saying actually makes sense. Versus years and years of just stuff, which is unfortunate.
Yeah.
So how common is it for like teens, kids, adolescents to have pelvic health issues? Because it's not even as a PT, it's not something that I associate with kids, right? It's usually, men, grown men, women, especially postpartum, prepartum type issues.
Right. So I think if you look for a generalized statistic, you'll probably find, something that says maybe 10% of the pediatric population in general has some kind of issue with bedwetting. And then if you break things down by age, as you get more and more towards adulthood, the percentages go down. But even, teenagers, there's still, I think, about 1 to 2% of, 15-year-olds and up, who still experience bedwetting. And the longer it goes on, the longer it's going to persist.
Okay. And that's hard for them. Do you have to deal with like the mental repercussions of that, especially as you get into the teens? Because that's really difficult.
And I've seen a broad spectrum. I've had teen boys who come in to work with me who are really on board. They want to get better. They're tired of this. And then other ones who are just kind of like, oh, well, whatever, I wet the bed, big deal. And then other ones who are just totally resistant to therapy and, super anxious. And then we have to get more, behavioral health professionals involved. So I've really seen just like a broad spectrum with the adolescents. but yeah, there's definitely a big emotional component to it that can really go on into adulthood. I mean, I've had calls from an adult male a few
Mhm.
times, and they'll say, do you help with bedwetting? And I've said, unknowingly, kind of ignorant at the time because I was focusing on working with children. I said, okay, so how old is your child? And they say, oh no, it's for me. I said,
Oh,
oh, I said, okay, so this was, an issue that's probably been persisting for a really long time. Um, so yeah, so there's definitely a lot of social and emotional, components to this that, can persist for a long time.
yeah. So if these kids have issues as children, obviously, and they
Mhm.
don't get resolved, obviously some of the bedwetting stuff can persist. But if the pelvic floor, like constipation type things,
Mhm.
do they resolve on their own eventually, or are there just long-term consequences of that?
There's no actual studies, at least that I found yet, but yes, I believe
Mhm.
that there's long-term issues, and because there's really no correlation yet with, let's say, constipation in children, and let's say, hypertonicity of the pelvic floor and sexual dysfunctioning and sexual pain in adults. But if you have constipation that persists from childhood, you're going to develop a tight pelvic floor because it's always holding up that load of stool. And then as you go forth through adolescence and into adulthood, and the time if you are ready to become sexually active, that person might experience pain and they don't know why. And then going to see an adult pelvic floor physical therapist and learning history, they might say, oh, if you've had such long-term constipation, you develop tightness in your pelvic floor muscles. So I do
Mhm.
think that there is a big connection with adult pelvic floor dysfunction and their pediatric history.
Gotcha. So with adults, you go in, you take a subjective, you do exams, things like that for the initial exam and treatment.
Mhm.
What does a typical examination of a pediatric pelvic health patient look like?
So depending on the age, really, especially for the little ones, the kids under 10 who come
Yep.
in. So they come in with their parents, usually both. And I spend a lot of time talking to mom and dad, letting the child play, or if they want to just sit in mom and dad's lap, that's fine. And just getting to know them. And I just talk to them, just a normal conversation. The biggest thing that you need to do when you're working with children is set up a rapport. So, and obviously you need to do that for adults too, but with pediatrics and dealing with such a sensitive nature, it becomes, even more important. And I also tell the parents what's going to happen ahead of time so they can help prepare the child. So I have toys that, I'll have them play with in the office, and then I always engage them in some playful motor activities. So we're not jumping right on the table and doing, an examination of their genitalia. We're setting up, that foundation. And I also need to know their motor control because that plays a part in pelvic floor health. I need to know when do they have their milestones, and go through kind of a typical pediatric evaluation before we even get to the pelvic floor part.
Mhm.
And then during that time, if I feel the child is okay with it, if they're ready, and if they give permission, because consent is always needed, even in pediatric cases, then I'll have them do disrobing from the bottom down. If they allow me to visualize, that's great. If they don't want to, I don't. And then I'll explain to mom and dad, what's kind of look for as I ask them to go through a couple of, different tasks with their pelvic floor.
Gotcha.
Yeah.
And with that, then, kind of to follow up, what does treatment typically look like? Mm,
So depending on, what I find with the assessment, of course. So let's say if a child has low muscle tone and, poor pelvic control, poor balance on one leg, they're not able to hop or jump appropriately, So we'll go through some of those developmental tasks to work on at home. We'll go through some abdominal strengthening. In cases like massage, we go through a lot of home things for the parents to work on. So,
mhm.
different manual techniques for the stomach. We go over posture and positioning on the toilet, some breathing exercises, some yoga, and then for the actual manual part in session that I do, I'll either do some maybe visceral mobilization. We use biofeedback a lot. And again, that requires the child to be disrobed. So again, always has to be within their comfort level. Nothing internal is done on kids.
Okay.
The only time an internal would ever be done on a child is if it's given consent by the doctor, the parent, and the child. But to this date, I've never done an internal on a child, including, a young teenager, because I think the ramifications and the consequences of doing that would be, counterproductive of why they'd be coming in. So if we want to try to have a child or an adolescent relax their pelvic floor, and they send somebody who's going to, either probe them with a tool like they may have had already done in the past by an MD, or somebody getting close to their genitalia, they're just going to tighten up. So,
right.
Yeah. So we go through a lot of relaxation and down training, calming the nervous system, and explaining to parents, how to work on that at home too.
Gotcha. So obviously things like bedwetting, maybe some constipation, things like that are fairly normal given, with ebbs and flows. What would you say to a parent that is dealing with constipation or bedwetting? When is it not normal anymore for that child to have those issues?
So bedwetting is not normal after the age of 4.
Okay.
So they may hear differently, especially from their, primary care doctors. And bedwetting can be a common issue with children, but it doesn't mean that it's normal. So especially if a child went through potty training and let's say was dry for a period of, 6 or 7 months and then just started bedwetting out of nowhere. So that's a cause for concern and a cause to see the doctor. So of course we want to rule out anything medical going on with the kidneys or any other kind of medical diagnoses that could possibly come up. But then at that point, it's definitely beneficial to seek out a pediatric pelvic floor PT to, address what's going on. And it may be just, some constipation that needs to be addressed and, some behavioral habits during the day. A lot of children will hold in their urine, especially if they're involved in playing and games and, things like that. And then, that develops some kind of dysfunctional voiding patterns for them.
Gotcha. And then in terms of like preventing the whole constipation route, does that happen? Does that start with potty training, or is that more later, kind of like what you were saying, when kids just have a mind of their own and they start holding it in on themselves?
It can start with potty training. So if there's no perfect age to start potty training. If some people do it around 2 years old, which is fine, as long as the child is giving you signals that they're ready. Other people who start the potty training before the child is ready and really do a regimented schedule. Their child may get dry and may become potty trained, but they're also taught to withhold. So that sets up the foundation for constipation. So it can definitely result from potty training if it's not done, consciously and, with some patience. And, if it's done before the children are ready, then there can be issues after that. But I think in most cases, if you have the child just take their time with doing it, usually works out pretty well. And then constipation, again, might develop later, depending on their digestive health, their dietary habits, their nutrition. Those are all other, issues that are connected with the constipation.
Gotcha. And then in the adolescent and teen population, outside of bedwetting, what are some other common issues that you see in that population?
I've worked with adolescents who have endometriosis, who have pelvic pain of some kind, who might not have been diagnosed with endometriosis, but maybe it's pending. And they just haven't had the surgery yet to see, if it's present or not. Because I've had children who come in, even experiencing nerve pain in their pelvic region. A lot of time it's athletic children or children who are involved with a lot of activity like dancing or, running, baseball, you name it, like some kind of heavy duty sporting activity. So they're doing the same kind of repetitive motions and patterns over and over again, and maybe relying a little too much on, holding in their stomachs, and they're developing some, extra pressure there and, hypertonicity in the abdominal region. Could be all different, could be all different reasons, but I do see adolescents for pain, besides, fecal soiling and bedwetting and constipation.
And then you were mentioning, nerve pain in the pelvis, or even just pelvic pain in general. What does that typically look like? Because sometimes a lot of people will think that it's, groin pain or hip pain, maybe even. and even just stomach aches. So
Mhm.
for you, what is something to look at or look for when people are telling you about those types of issues?
If an adolescent is complaining about nerve pain,
Mm-hmm.
so kind of going through similar to you would with an adult, just going through those different pain patterns, and dermatomes, and just testing different sites and seeing how their sensation is, seeing how they respond to just soft, myofascial work and gentle
Mm-hmm.
stretching. Um, and we still go through the pelvic health backgrounds because I want to know, is there constipation there that hasn't been addressed, and how's the voiding schedule, are they withholding, because a lot of times I find the connection with children, if they're holding their urine
Mm-hmm.
in, they'll get that tightness in their lower pelvic area, and then that translates toward the pelvic floor. So even if I did an external with clothes on, just feeling around their sits bones, around their ischial tuberosities, I'll feel some, kind of spasming, and they'll tell me that it hurts. So,
Okay.
yeah, so it really could present so many different ways, but it still, requires some, exploration in terms of finding where exactly the pain is.
Gotcha. And then with kids who can't necessarily communicate as well, is it more reliant on like palpation and just a general of like it kind of hurts down here type of thing?
Yeah, or I'll ask them certain questions. I'll
Okay.
ask them, did it hurt, the last time you went potty? Did it hurt when the poopy came out? Did it hurt when the pee came out? Just speaking in kid language. When you're
Mhm.
speaking to somebody that little is really important, because they're gonna just refuse to go to the bathroom, and we have to figure out why. Is there a fear?
Right.
Are they not comfortable sitting on the toilet? Are they not supported enough sitting on the toilet? So it's just doing some detective work with questioning, maybe creative questioning to get some more information out of them.
Cool. Awesome. So if you had like three tips for, parents and or adolescents and teens, what are the top three things that you would tell them to be able to improve or prevent pelvic health issues?
So we always want to start with digestive health and hydration. So we want to make sure our kids are getting enough water. Soda, I don't count. Juice, I don't necessarily count too much of that either. So we want to make sure we get enough water so that the urine is a nice pale yellow color. Um,
Mhm.
and then we want to make sure that they're sitting down, taking enough time to chew their food, that they have a variety of food on their plate, that they have enough fiber. A lot of
Mhm.
times children who are picky eaters, who just want to eat the chicken fingers and French fries, guess what happens with their stool? It's not going to be so great. So in that case, sometimes having a feeding specialist help out with those feeding patterns might be helpful, or an occupational therapist if there's some sensory processing issues surrounding food. That can be a really valuable asset too. But those are definitely the two most important things. And then working on, just getting that scheduling and that tracking done for when your child urinates, for when they poop. Moms don't always have the time to ask a child, did you go potty? Did you poop? Did you pee? So just remembering to, ask them once in a while, to make sure everything looks okay. Teaching children what their poop should look like. It's not supposed to be
Mhm.
hard little nuggets. It's supposed to look like soft serve ice cream. So
Mhm.
that's a visual that most kids can kind of relate to, and they usually get a giggle out of it too. So just having kids take an active role in their digestive health and their pelvic health, makes a really big difference.
Awesome. One thing I wanted to talk to you about, and just because of my kind of background in chronic pain and things like that, trauma is always a big factor in that. Do you find that is an issue with pelvic health, potentially maybe with kids, but more so with like adolescents and teens?
Um, I've worked with adults who've experienced pelvic trauma. To this point, I haven't worked with children who've experienced pelvic trauma. I've worked with
Okay.
children, or more so adolescents, who've um, had more mental health concerns, or maybe had experienced, bulimia or anorexia,
Mhm.
those kind of diagnoses. So not direct pelvic trauma. but if there's any time a concern that a child has undergone or is currently undergoing pelvic trauma, I mean, we're mandated reporters. So for an adolescent, that I would be obligated to report the case. But so far, it's more, the cases that I've seen more, there's a lot of behavioral management, family education, child education. I'm working on addressing that overactive nervous system.
Gotcha. And do you typically find that pelvic floor issues are in conjunction with other like musculoskeletal problems, whether it be, hip pain, back pain, that kind of thing, especially with kids?
With children, not as often, because it's not too often that you'll find a child that complains about back and hip pain.
Okay.
What the association that I see more of is the low muscle tone. And there are studies out there about that. So for children who have low muscle tone, they may have slower GI motility. So meaning, the movement of the stool through the intestines can be slower than other children's. So it's easier to get backed up. It's easier to be constipated. Plus, if you have lower muscle tone in your abdominals, you don't have that extra support for your digestive system because our abdominals help to move things along. So in that population, constipation is more prevalent. And then if you have the constipation long enough, that leads to fecal soiling. So those things are all closely connected. So I would say, doing the musculoskeletal evaluation during my sessions is really important. I want to see the child's alignment, look at their overall strength. Is it a child who needs orthotics? Look at them in single leg stance. How is their pelvic control? And that really gives me a good idea of, where we need to start.
Okay, very good. And then in adolescence, you already mentioned it with sports. What kind of things would you say if you are having, pelvic floor pain or pain in the hips or back? What kind of things would you ask them to do to prevent or start working on that kind of stuff?
First, it depends on what's bringing on the pain. So if it's something that they can show me, I'll do some functional movement analysis with them, just doing the activity in front of me. A lot of times things are connected to breathing. So if it's something that we can change the breathing pattern for without, changing their performance, because, every athlete doesn't want their performance to be altered. That's a big thing. So we want to make sure that these kids and these adolescents, that they're breathing in fully, they're not holding in their breath. That's definitely going to affect their pelvic floor because our respiratory diaphragm is directly connected to our pelvic floor. So just going through that analysis, and I say, okay, show me, how are you doing this activity? And let's see, what we can change.
All right. Fantastic. That is awesome. So I learned so much just in the half hour that we've been on. That was just like information bombing for me that I have to go and process.
I tend to do that. Sorry.
No, that was awesome.
Okay.
Do you feel like there are any misconceptions in the general public that you would like to say, like, this is not true, especially when it comes to kids and adolescent teen pelvic floor and pelvic health?
Yeah. Bedwetting is not normal. Especially after the age of 4. And it can definitely have a lasting impact on the family, on, the social relationships of the child. And, for parents, if your child is waking up almost every night with a wet bed, that's disturbed sleep. That's a big deal, especially if the child has to go to school the next day and parents have to go to work the next day. It's a big deal. So it can be frustrating to hear from another healthcare practitioner, like, oh, it's normal, they'll just grow out of it. In the meantime, families are being denied sleep, on a regular basis. That has a big impact on things. But the constipation, one big thing I tell people is that constipation can be present even if you have a daily bowel movement. So there's really no way to rule it out for sure unless you get an X-ray. So for children who have constipation, they can still have small, soft bowel movements because maybe there's some mushy stool that's moving around, hard stool, and exiting the body that way. So it's just a lot of education that needs to be, given out there that, I'm trying to do. But I always tell parents, seek help. There is help for these things. You don't just have to keep telling yourself, all right, one day they're going to grow out of it. And then like 10 years later, they're still waiting for them to grow out of it.
Right.
And pediatric pelvic physical therapy is conservative. So a lot of times these children are going from, they're just complaints at home to seeing all these doctors, they're getting probed, they're getting, digital exams, and that in and of itself can be quite traumatizing for a child. So, as PTs, we always say, let's try conservative treatment first. And then if we need to seek out more invasive testing, then we do that. We refer on. But I always say, let's give this a shot first, because there's so much we can do, and there's so much of an impact that we can make just by doing pelvic floor physical therapy that, we may not have to go the route of getting all these other invasive tests done.
Yeah, definitely. Bedwetting is something that I think is like, even in movies and things like that, it's like, it's something that is stigmatized and people don't like to talk about it. Kids don't like to talk about it potentially. So with bedwetting then, other than like some hypertonicity of muscles, of the pelvic floor muscles, what are some of the common causes of bedwetting beyond that age of 4?
Constipation is a huge one.
Okay. It all comes back down to the constipation.
Yeah, a lot of constipation involved in pelvic floor health. There really is. It's not the cause of 100% cases of bedwetting, but it's the cause of a lot. But also, if a child is, let's say having sleep apnea, that could be another cause of bedwetting. If there's sudden and severe onset of bedwetting, then unfortunately, that could be a sign of diabetes. So in that case, going back to your doctor and discussing things with them is important. So there are other reasons that bedwetting can occur, but I find that majority of cases it's linked to constipation. And then once the constipation is truly addressed, and that can take time depending on the amount of time a child has been constipated. It's not just a quick and easy fix. But once it's truly addressed and monitored, then you see the progress with the bedwetting.
So do you do, as a pelvic floor therapist then, do you do any like visceral work? Because it sounds like consultations are very, very involved. And cool, awesome. So that's like just hands-on, like a visceral movement and natural movement throughout. Can you talk about, would you be able to talk about that a little bit in terms of like, what the goal is and what it might feel like for a child too?
And visceral mobilization is really gentle. If a child is really impacted with stool, then that's not something I'm going to do right away. More so, we need to get that child emptied out. So it's a lot more education about, defecation mechanics and talking to the parents about how they're going to do a clean out for the body. Because if they just have tons and tons of hard stool in there, the visceral mobilization itself, it's not going to be enough to have them empty out. So so if there's lumpy hard stool in there, that's really the priority is getting that out. But visceral mobilization is really helpful just to stimulate some motility and to help get things to move along once they're cleaned out. And just like myofascial work and massage, all these things are really great methods to help stimulate bowel movements. So parents will tell me, after I teach them, home exercises and home program, they'll tell me, oh yeah, I did the massage for a few minutes and then he went to the bathroom. I said, okay, great. Keep it up. So, these are all just different methods to support the motility and to support those, bowel movement habits. But if there really is, a lot of impaction, if there's true constipation in there, then we have to have that cleaned out, usually with the help of, some kind of medicinal aid.
Gotcha. Got it. So, okay, that's awesome. Do you have any tips for parents to prevent that from happening? I know we've talked about, diet, hydration is a big thing. And I know with hydration, it's not just to help with urination, but also to actually help with stool function and motility through the viscera there. Can you talk about that a little bit? Because I don't know a whole lot. I just know that it's important.
Sure, absolutely. So, with hydration, as stool is formed in our large intestines and it travels through the large intestines to make its way out through the rectum and the anus, water is reabsorbed into the body if it's needed. So if we don't have enough water in our body, then more and more water is going to be reabsorbed back into the body from that stool. And that's going to make the stool really hard and really dry. So then that's going to make it harder for the stool to exit the body. So then a pediatrician or somebody might recommend to a parent to give their child Miralax, because that's an osmotic laxative, meaning it draws water back into the stool to make it easier to move through the body. So So having your child drink enough water so that the stool looks like nice and mushy and it's like a soft log, then you know that they're getting enough hydration. If it's hard nuggets, if a child is straining and develops, anal fissures and bleeding and tears and things like that, you know that that stool is just way too hard. And you have to work at getting it really, really soft.
I think that's a great tip for adults too, especially adults that have, just jobs where, you're on your feet and you can't necessarily make it to the bathroom when you need to go to the bathroom. Just try.
And a lot of adults don't want to use. A lot of adults don't want to poop at work.
Yes,
they just don't. So
yeah,
right. And they squat and they hover over the toilet. Yeah. So parents have and adults have dysfunctional voiding habits as well that we have to address. Yeah.
Yeah.
But hydration and fiber, diet, all those things come into play with stool formation. We want it to be nice and soft.
And ideally, how many times a day are you supposed to be voiding? And I've heard different, ideals, once or twice a day, or is it just person dependent?
It's person dependent. If you look at the criteria for constipation, they actually just changed it recently. So I think we tend to throw around the word constipation. Somebody might say, oh, like I didn't go to the bathroom yesterday, I feel so constipated. So technically that's not true medical constipation. That's more if you've had, to meet the certain criteria that's established, the room criteria. But if you feel like, there's hard stool in there, and, you're having difficulty going, but you're going twice a day, like that's still a sign that there's an issue, even if you're still going twice a day, but maybe it's like only a little bit, or like I said before, those little nuggets are coming out. If you have to strain to poop, those are all signs that, there's some kind of dysfunction there, even if you are going twice a day. So for me, it's not just the amount of times you're voiding a day, it's the quality of that stool. Having said that, some people go once a day and it's fine. Some people go twice a day. Everybody, is a little bit different in terms of how often they have a bowel movement.
Great. So for parents especially too, it's more the quality than the quantity of schooling.
We always want to look at your child's poop, and that's not always a priority on a parent's plate. It's a busy day. I get it. But once in a while you need to take a look in there and just see what's going on. You can kind of take a listen when the doors close. Do you hear your child straining to poop? Are they pushing really hard? Then like something's going on. It has to be addressed.
Gotcha. Cool. So it sounds like most of your treatments are just based around a ton of education for both parents and kids and teens.
Absolutely. Absolutely. A lot of education. I mean, there's still, there's still the regular like manual work that I do and, my feedback in the office and stuff. But there's a lot of education because just like with any other PT practice, when the patient leaves, they're on their own at home. So we have to give them plenty of things to work on at home. And a lot of this is lifestyle modification for the child and their family. So lots of coaching involved.
So if somebody were to come to you, what's a general normal plan of care in terms of like how many times a week they would need to be seeing you for, how many weeks, things like that?
So with my practice, I have a private practice where I see patients for extended periods of time. So the first session with me is always about 90 minutes. And then follow-ups are an hour. So that gives me, plenty of time to address, history and, our objective findings. And, like I said before, I want the child to feel really comfortable with me. So we're not rushing to get through our session because I have somebody waiting, outside the waiting room, for their appointment. So we always can take our time, in that first session, a child might not really be ready to even sit on the table for me. They may be just scared out of their wits, and I just want them to get comfortable with me, get comfortable with my face. Let's have some laughs. Let's have silly conversation. Let's play games and stuff. So it just depends on the child. But having that, extra time really allows for much greater ease and a lot more effective treatment.
Yeah, that's the dream. It's for initial hour follow-ups. That's awesome.
Yeah.
And they're all like one-on-one appointments, I'm assuming.
Yes.
That's
and
great.
Always with their guardian present if they're under 18.
Right. And especially because there's so much education involved. You tell a kid one thing and their mom and dad's going to be like, so what'd you learn today in pelvic floor PT? And they're like, oh, nothing.
Yeah, no, because really the parents, have an active role. And I tell them that
Right.
before they even come in to see me. I said, you're going to be given work to do. It's not like I'm waving, the proverbial magic wand and everything is just 100% better. I wish, right?
Right.
But
Right.
yeah, a lot of this is stuff that the family has to implement at home because it requires some lifestyle and behavioral changes. And that's where they're going to find the most success.
Yeah. And I find that that's always the hardest part, no matter, what specialty you're in, when it requires most healthcare changes require some lifestyle changes. And that is truly the hardest part for people to implement. And
It
really,
does, but if it makes if it makes a huge impact, and it's not always the impact that we think is important. So if a child is coming in with bedwetting nightly, that means they can't have sleepovers. Maybe they can't attend a Boy Scout sleepover or camp out. Like I said before, mom and dad might be waking up every night to change sheets. So just from those aspects alone, like to have that be changed is huge. So we're not saying, oh wow, the pelvic health is just so much better, but it's really the functional and the social impact that matter even more, because that child wants to be able to, go out and do things with their friends without worrying about, wetting their friend's bed at night, and they want to do sleepovers and, do sporting activities without worrying that they're going to wet through their uniform. So really those things are just major.
Yeah, yeah. And again, it's the same thread through all of PT, and I would say generally healthcare in general. It's like we'll help you fix a problem, but really that problem is going to affect the rest of your life.
Right. And it comes back down to like, patient goals. What's your goal for getting rid of bedwetting? What is it that your child can't do because they're wetting the bed or because they're constipated? And that's, and that's really what their goals are.
Yep, totally. Well, awesome. Thank you so much. Are there any huge nuggets of wisdom that you would like to drop?
And I love how you use that word nugget after we've been talking about that.
He's my psyche now. Yeah. It's just going.
Take care of the pelvic health. I mean, if there's an issue, don't take they'll grow out of it for an answer. In this day and age, you don't have to. There's so many of us out there who want to help, and you can easily find us through Google searches or on pelvic floor directories. And there's so much that could be done to help these. And the sooner we intervene, the better. It's definitely easier on the child to get rid of constipation after a year rather than 10 years.
Right.
Because the longer it goes on, the longer it persists, then it's going to be a little more challenging to correct. So seeking help earlier than later is always better. And just keeping up hope and giving your child hope that even if they've had these symptoms for a long time, we can still make a lot of great changes.
Yeah. And I love doing these because I get to network with amazing people like you and get to meet awesome people like you. And now I'm like, oh, well, I know exactly what kind of person you need to see for that, because I can't help you, but it's not just a weird thing that I'm like, you can just brush off now. Right. So it's nice to be able to kind of spread the knowledge, even if you're not the one treating that specific thing. Now you know who to take that person to.
Right. Absolutely. And that's important, to always be able to refer on when it's something that it's not your area. Yeah.
100%. So if people have questions or want to talk to you a little bit more or message you, where are some good spots for them to find you?
So I'm pretty active on Instagram. My handle is @Marina, MARINA, Pelvic PT. My website is www.marinacpt.com. And those are probably two of the best ways to find me. My email is marina@marinacpt.com. So any of those ways, you'll be able to reach me.
Awesome. Well, thank you so much for your time.
You're so welcome. This was fun.
Yeah, for sure. I would love to, keep in touch and keep the line of communication open for.
Absolutely. All right. Thank you so much for having me.
Thank you. Have a wonderful morning.
All right. You too.
Bye.
Bye.